I'm delighted to be participating in the TCOYD virtual conference. I'm Dr. Heather McDonald-Bloomer, a rheumatologist from the University of Toronto in Canada and a longtime friend of TCOYD. The session this afternoon is Oh, My Aching Joints, Musculoskeletal Issues in Diabetes. Over the next half an hour or so, Dr. Edelman and I thought it might be helpful if we talked about some common musculoskeletal issues in diabetes. And in particular, there are two areas that we're going to look at. I'm going to talk about why does it lift to hurt my arm? And as you can imagine, this is going to be relevant to shoulder-related issues. And why do my fingers look gnarled? Through our discussion, I'm hoping to walk through a little bit of the information that might be helpful to talk about frozen shoulder, trigger finger, osteoarthritis, and a few other conditions that are quite common in both type 1 and type 2 diabetes. So that we're all on the same page, I thought it might be helpful to go through Rheumatology 101 just in a couple of minutes. So if we think about the musculoskeletal system, it's really the system of muscles, joints, tendons, and ligaments, and how those all work together to keep our bodies upright and to allow them to move relatively smoothly. So you can see from the small picture in the middle, this is actually a knee joint. And the muscles that they're looking at through here are the muscles in the thigh or the quadricep muscles. So I think all of us can see that those muscles are easily activated and really important for standing and really important for bending and straightening the knee. When we look at joints, I put out a little picture of the hand. The hand has got a lot of bones, and where two bones intersect become the joint. And so there are many joints, and that allows for an excellent range of movement in the hand, particularly when it's working appropriately. And then lastly, looking at ligaments and tendons, the largest ligament or tendon in the body is the Achilles tendon. I put a little picture here. You can see that it's nicely mapped out in red, and you can feel that tendon. And the tendon is where the muscle from the calf area comes down and attaches to the bone. And that's important so that the muscle actually has some leverage and allows us to move. So those are sort of the main components that we look at in terms of the musculoskeletal system. I thought it might be helpful as well just to look at, well, what do we mean by itis? Well, itis refers to inflammation. And we have arthritis, which is inflammation of the joint, which eventually can lead to damage of the joint. We have tendinitis, which is inflammation of the tendon. And there's one other structure that might be helpful to think about, and that's called a bursa, which is a little cushion that actually helps protect the tendons and ligaments and muscles from getting rubbed on bony prominences. And these little cushions or bursa can get inflamed as well, and that's known as bursitis. So itis is very important when we're talking about musculoskeletal issues in general, and in particular those for people with diabetes. There are over 100 types of arthritis that a rheumatologist might see in one's career, the most common of which is osteoarthritis. And we're going to spend some time talking about this both in the shoulder and in the hand, but it has a number of areas that it likes. And you may have experienced or know people who've had degenerative or osteoarthritis in the knee or the hip, and it can also affect some of the joints in the spine. The second big category of arthritis are what are known as inflammatory kinds of arthritis. And the mechanism, what causes this is a little bit different. The primary change is that there is inflammation that occurs in the tissues in and around the joint. Gout is a really good example of that, where people will find sudden onset of a hot, red, swollen joint. It comes for a week or 10 days, and then it abates. And I think everybody would agree that they can see the inflammation, they can feel the inflammation. Gout is a little bit more common in some populations, and we do see it in the type 2 population, perhaps a bit more than the type 1. And then another form of joint inflammation is rheumatoid arthritis. It's an autoimmune process where there's inflammation in the joints, and that affects about 1% of the American population. And there is some overlap with other autoimmune diseases, including type 1. But back to our agenda. So why does it hurt to lift my arm? So there are a couple of different processes that we're going to talk about today. So we're going to look a little bit at osteoarthritis, frozen shoulder, and rotator cuff tendinopathy, which are three quite common causes of arthritis of joint and shoulder problems, which I would see in my office. So if you think about who has had a sore shoulder and what did that feel like and how did it present or what were the features there? So I think there are a couple of different scenarios that I hear quite frequently in my office. One is somebody who said, when I'm sitting quietly, my shoulder's fine, but if I go to reach for something, I get this sharp pain. It's really, really sore. Another version that I might hear is, my shoulder's sore all the time. It's nagging, aching kind of thing. And when I go to movement, it just doesn't move as much as it should. And a third really common scenario is somebody who says, I can manage during the day, but as soon as I lie on my shoulder at night, it just drives me crazy. So those are a few examples, and I'm sure you could all add your own version of that. The shoulder is a complicated joint. It's actually 4 joints. So we've got the main shoulder joint, which just for interest is called the glenohumeral joint. And then we've got joints where the collarbone attaches to the main part of the shoulder, where the collarbone attaches to the breastbone. And then the wing bone or scapula at the back is also part of the shoulder mechanism. So you can see that there are lots of areas in the shoulder that can be uncomfortable and can be problematic when people have shoulder pain. There are also a lot of ligaments and tendons and muscles around the shoulder, and we're going to talk a little bit about that when we talk about rotator cuff tendinopathy. And then, as I mentioned, there are these little cushions or bursa, and the shoulder has several, just so the tendons and muscles don't get rubbed and frayed as they go over the bony prominences. And so you can get bursitis in the shoulder as well. Although those are all the things that can go wrong, when the shoulder is working well, it gives us really wonderful range of movement. And you can reach forward to get plates off the top shelf in your kitchen. You can reach sideways to get your coat on. You can reach backwards to be able to get your wallet out of your back pocket. And you can do complex movements like washing your hair, where many of those different ranges of movement are all brought together. So the trade-off is that it's a complicated joint, but we have really, really good range of movement in the shoulder, which is important for the way we function. So if we start off with the osteoarthritis, this is a picture of the bones in the shoulder. So as I mentioned, there are a number of different ones. This is the main bone in the arm. This white area is the cartilage that covers the very end or the ball part of the area. And you can see some of it looks quite white and almost like pearl. And then this cartoon shows us areas where it's cracked and red looking with little streaks coming through. So you can see there are these little areas that have opened up and gotten damaged. And that's trying to picture what osteoarthritis is. The way I think about it in my own mind is that the inside of the joint, the cartilage part, is like pearl. And if you think about taking a pearl, you could put it in the palm of your hand and you could rub it around on your hand for hours, and it wouldn't cause any irritation because the pearl itself is so round and so smooth. But if you put a dent in that, if you cut a little piece out of it so there was a rough area, you can imagine that as you move that pearl, for the first few movements, it wouldn't be bothersome. But when you did that for a long period of time, it would become really irritating and your hand would become quite sore and the skin could get inflamed. And it's exactly the same with osteoarthritis. When the joint is working the way it should, and all of this looks like pearl, you can do all the activities that you want without problem. But as the cartilage breaks down, then the more you use that area, the more uncomfortable it becomes. So that's kind of the nuts and bolts with arthritis in the shoulder. You can imagine that it doesn't matter which area is affected or which range of movement. Mornings might be fine. The end of the day, when you've been using the joint more, is going to be uncomfortable. The secondary is frozen shoulder. So this is looking kind of at the next layer in the shoulder. So you can still see the same bones. Now you can see there's this capsule, this sort of area that goes around the shoulder to hold the two pieces together. And again, the red tries to portray some inflammation in there. And often with inflammation, we get a bit of shrinking down or tightening up of that capsule. So that becomes frozen shoulder, or what is known more medically as adhesive capsulitis. And this can occur in upwards of 20% of people with diabetes. It does occur in the normal population, but not as frequently. And we really don't know what the cause is. It's perceived or thought to be that something seems to injure the area and causes tightening of this envelope that surrounds the shoulder joint. And so with that, people may or may not get pain, but the big issue that really interferes with normal activities is there's decreased range of movement. And it tends to be for many of the ranges, but particularly going sideways. So raising your arm up to try to wash when you're in the shower, raising your arm up to get a blouse on can be problematic. Or certainly in my part of the woods, getting your winter coat on can be a little bit challenging if you can't get your arm even to shoulder height or 90 degrees. There are a number of different ways that we can manage a frozen shoulder, and one of the really key or pivotal issues is to do some gentle range of movement. So it's interesting, when we talk about exercise, there are a couple of different things. We talk about exercise as part of just our general fitness, going out for a walk or, doing some gentle weights or being on an exercise bike. Therapeutic exercise is a little bit different from our day-to-day activities. So therapeutic exercise are exercises which are really specifically targeted to try to address a specific health issue. So with something like a frozen shoulder, the physiotherapist, kinesiologist, or exercise scientist can help show exercises that are really designed to try to stretch that capsule and get it back towards normal functioning. And it's a really important part of what we do for frozen shoulder. The challenge is it often takes 3 to 6 months for this exercise to gradually stretch this capsule. And so in the meantime, we look at pain medications, specifically things like acetaminophen or Tylenol. In some people, we will use anti-inflammatory medications, and you'll see that I will talk about them a number of times over the course of the next 20 minutes or so. There are a couple of really important caveats. Anti-inflammatory medication can be hard on the stomach, so if people have got bleeding issues or stomach ulcers, you shouldn't be taking them. And secondly, we know that people with high blood pressure or kidney problems can run into very significant and worrisome complications with anti-inflammatory medication. So the caveat there is really you should only be taking those under the close supervision and advice of your healthcare provider. There are some available over the counter, but I would caution you not to use them if you fall into any of those categories. For a number of people, if the sort of more gentle therapies don't work, then we can do things like a cortisone injection, where we do take a cortisone substance, which is an excellent anti-inflammatory. We put it right into the joint. It can be done quite safely as an office procedure. We now do it under ultrasound on a regular basis, and it tends to be well tolerated by most people, although I do caution that you do have to watch your blood sugars for a couple of days thereafter. It will make blood sugars go high. So for those people who aren't comfortable in managing your own insulin or other therapies, you need, again, to make sure that your healthcare provider is aware and gives you the appropriate instructions. So I put this picture up. This is actually a picture of the Big Ben clock in England, but I do it because frozen shoulder is something that they say if you leave it alone, it will actually resolve on its own. They talk about 3 phases. So there's the freezing phase where you're starting to lose range of movement, the frozen phase where it's just not moving very well, and then the thawing phase where without any particular intervention other than time, things will just improve. The challenge is it can take up to 2 years for that to happen, and most of us aren't patient enough to wait 2 years to get our shoulder back and moving in a semi-normal fashion. So moving on, the next area to talk about with the shoulder, it would be the rotator cuff tendinopathies or rotator cuff tendinitis. And you can see again that we're still looking at the same thing. You can still see the collarbone here. This is where the collarbone meets up with the rest of the shoulder complex. Here's the big bone in the arm called the humerus, but we've now layered in more of the muscles and tendons and ligaments. And the rotator cuff refers to 4 big muscles that help us move the shoulder in its very complex way of moving. And one or all of those can get affected. They can be injured, they can get inflamed, and that becomes rotator cuff tendinopathy or tendinitis. From a patient perspective, it tends to cause pain, often with specific ranges of movement. And so people say, when I'm sitting, I'm fine, but I go to reach in a certain direction and I get this really sharp pain. I feel like, something's going to fall out of my hand. It's that intense. I can then bring it back to a more comfortable range and the pain dissipates. And that's a relatively common presentation. And depending on which of the 4 muscles, depends on which activity is most problematic. The other thing that's really interesting about rotator cuff tendinitis or tendinopathy is that sleeping on that side can often be really uncomfortable. And so when patients say to me, I can sleep on my left side, but as soon as I turn on to my right side, within 15 minutes, I'm wide awake and my shoulder's really sore, it kind of triggers me to think that maybe there's a rotator cuff related issue. Along with pain, there's decreased range of movement, and it may not be in all directions. It may be just in the direction where you're using that specific part of the rotator cuff mechanism. And with both pain and decreased range of movement, some people perceive that there's a sense of weakness as well. So once the diagnosis is made, again, we look at treatment, and you'll see that there's some common themes here that we use some very gentle stretching exercises, again, under the guidance of the physiotherapist or kinesiologist. We use the same type of pain-relieving medications with acetaminophen as our first choice. And for those people who can manage it, then maybe with anti-inflammatory medications and cortisone injections can also be helpful for this population of patients as well. So there are a few things that we haven't talked about. So the rotator cuff muscle can actually get torn rather than just have some inflammation or some small amounts of injury. That's a totally different discussion. We make that diagnosis on the basis of ultrasound or MRI, as well as a specific clinical presentation. And my orthopedist colleagues often get involved to try to look at whether or not surgical repair is possible. We also know that not all shoulder pain comes from the shoulder and all the complexity around that. And some people will have some osteoarthritis in their neck, but that gets felt in the shoulder area and clearly needs a different set of things for the complete diagnosis and for the treatment. And then there are other forms of arthritis that we have not talked about, which are common depending on age and stage, but not more common in people with diabetes. And so I haven't included them today. But I think the take-home message is if you get a twinge of shoulder pain every now and again, you're probably not going to worry about it. But for those people who get persistent shoulder discomfort or pain that's interfering with your activities of daily living or nighttime activities, it's really important to speak to your healthcare provider to see if you can come up with a specific diagnosis and with that, a targeted intervention. And most of the time, we can find some things that help us manage shoulder pain quite well for most individuals. So going on to phase 2, I thought, why do my fingers look gnarled? And there are, again, a lot of issues that we can look at from that. And I'll focus on just a few of them. So we'll look at osteoarthritis. We'll talk about trigger finger, Dupuytren's contracture, and what's known as the stiff hand syndrome. So starting with osteoarthritis, some of you may have experienced this, some of you may know people, but if you look at this person's hands, I will draw your attention to these little gnarled bits at the end of several of the fingers. You can see them on the index fingers in particular, and a little bit on the third finger. And if we look at that up close, you can see that where the joint is at the tip of the finger, it's quite thickened at that point. And if you were to feel that, it would be almost like feeling an almond. It's quite firm, and that's because it's where the bone has thickened in response to what it perceives to have some injury. That can affect a lot of the different joints. And as that happens, again, you'll see that the index fingers look a bit bony. You can see that it changes the angle of the finger. The skin gets quite tight because it gets stretched. And you can look at the middle row of joints as well, and you get a sense that there are some changes there. And you can imagine that A, this would be quite uncomfortable. And secondly, the ability for this person to actually be able to make a grip probably has decreased because so many of the joints have been affected. And this is quite classic osteoarthritis in the hands. So we know osteoarthritis is a breakdown of the cartilage, and the cartilage can be damaged from a variety of different causes. We'll talk a little bit about that in a couple of minutes. And again, similar to what we saw on the shoulder, this is now actually a picture of the knee, but it shows it nicely. The cartilage here with these areas where it's been cracked or damaged. And with that, you start to get a different way that the one bone intersects with the other bone, and that causes pain and irritation and inflammation. With osteoarthritis, for the most part, it creeps up over time. People generally don't go to bed fine and wake up with it the next morning. It usually takes months or even years for it to develop. And we know that it can affect one area. People might just get it in a knee, but it often will affect many, and particularly in the hands. The little cartoon that I have here is your right hand. And so it's showing the thumb, and the 3 joints in the thumb are very common spots to get osteoarthritis. The tips of the finger joints are common spots to get osteoarthritis, and the middle set of knuckles. We actually have no idea why the main knuckles don't seem to get affected in osteoarthritis in the vast majority of cases. And what does that do from a patient's perspective? Well, it often causes some stiffness in the hand, particularly if you've been overusing the hand. The areas that are affected will be painful. You'll find decreased range of movement, and the ability to make a full grip tends to decrease. So in the normal circumstance, you can get all of your fingers tucked down, but with osteoarthritis, people will find that some or all of the fingers can't tighten down. And as I mentioned previously, in the vast majority of cases, we'll find that the more you do, the more uncomfortable it gets, And that means a change in terms of how people can manage in their day-to-day activities. Osteoarthritis has a number of risk factors. Age is probably the biggest one. We almost never see osteoarthritis in a 20-year-old, and I think I almost always can find it in a 90-year-old. So as a general rule of thumb for each decade of life, it seems to go up exponentially. We know there are some genetic or family issues there, and so we'll often see that it runs through a family. Particularly, we see that it's more common in women than in men. And then for osteoarthritis, there are a few features that are important. So we do know that weight is an issue, particularly for lower extremity osteoarthritis. And so for people who are overweight, hip and knee OA, osteoarthritis is more common. We know that if people have had injuries, particularly knee injuries for soccer players, tennis players, baseball players, that can be an issue. But even with hand osteoarthritis, people who've had injuries to their hand, I think of people skiing and they fall and do this. They'll often find that they get more osteoarthritis in the injured joints. And then there are a few things where we don't really understand the mechanism, but we do know there's more osteoarthritis and hand osteoarthritis in people who have had diabetes. The diagnosis is pretty easy. Most patients will actually tell me that that's what they've got and say, my mom had it, I've got 2 aunts or an uncle who's had it, I'm pretty sure I've got osteoarthritis and that's why my hands are so sore. But the treatment is really the challenge. And it's, to be honest, a bit frustrating because we don't have any good treatments for osteoarthritis right yet. We try to encourage people to avoid activities that aggravate the areas that are the problem. Sometimes some topical rubs, heat rubs, cold rubs, analgesic rubs can be quite helpful. Tablet forms of both analgesics and anti-inflammatories, similar to what we talked about with the shoulder issues. And then there's a growing interest in some complementary therapies, although we don't have a lot of evidence. But I think every rheumatologist has patients who have done well with varying kinds of therapies, whether it's naturopathy, acupuncture, massage, curcumin and turmeric are certainly popular. And I think the issue is you just have to make sure that you balance the potential benefit with the potential risks before you enter into these, and make sure that all of your healthcare providers are aware so that if there are any adverse reactions or any co-reactions, that we can be prepared. So moving on from osteoarthritis, what this picture is showing you is somebody's looking at their right hand. It's looking at the palm side of the right hand. So if you hold your hand in front of you, then you can see the little finger on the left side and the thumb on the right side. And I'm actually going to draw your attention to the middle finger. So what you see here are what are called the flexor tendons. And the flexor tendons are what move when you want to close your hand. Your brain tells those tendons to contract, and they contract and allow you to bend your fingers. The piece that's really important to look at is that those tendons move in and out of a little envelope, and you can see the envelope running from here to here. When the tendon is functioning properly, we don't even think about it. That tendon just slides in and out of the envelope without a difficulty. But if you look here where the index finger is, you can see a nodule on that tendon, or an area of thickening of the tendon. And it doesn't take much imagination to see that as you're trying to straighten the finger, that nodule is going to get caught trying to go into that envelope, and the finger's going to stick. And so what we're talking about here is flexor tenosynovitis, or trigger finger. And it's where you get a swelling of one or more tendons on the palm side, and that thick area then doesn't go through the envelope, and it makes the flexion, the bending or the extension, the straightening of the finger really challenging. And sometimes it just affects the movement, but often it's actually very uncomfortable for patients. And people will say, oh, I'm holding the steering wheel as I drive to work and I have to peel my finger off, and it's really sore when I do that. So when we look at trigger finger, you may be able to feel the nodules in your own tendons as you bend and straighten. We know that when we traumatize the palm of the hand, that tends to be an issue. And so the recommendation is to try to avoid things that do that. And so aggravating activities. I put out this little hand grip because you can imagine that's really going to overuse the flexing tendons in your hand and can be a source of irritation. But simple things, carrying grocery bags or your purse or your briefcase across the palm of the hand can be really irritating if there's no cushion there. If you're holding something like a mop or a rake or a shovel, again, if there's no cushioning, that's going to put a lot of pressure on the tendons and can irritate them. And even small tools, garden tools, can be problematic. And so looking at the kinds of activities that you do day by day and seeing where you're putting direct pressure across the palm is an important step, because then what we try to do is put some cushion there. So whether or not you're buying kitchen implements that have got a fat grip on them, and I'm not pushing anything in particular, but I know Good Grips has actually partnered with one of the rheumatology agencies in Europe and the UK, and they designed their equipment so that people had some cushion and didn't have to make as tight a grip. Or you can take a foam wrap and put it around garden implements like a rake or something like that, again, so there's some cushioning there. So you're really trying to avoid repetitive grip and to cushion the grip when you're doing that. There are some splints that our physiotherapy and occupational therapy colleagues can make to try to minimize trigger finger, and some very gentle exercises that can be helpful to maintain a normal range of movement without aggravating things. Again, we'll try some pain relieving medications. Sometimes we'll look at some topical anti-inflammatory medications to see if that will just decrease the inflammation enough to allow that little tendon to flex in and out of the envelope without difficulty. Cortisone injections, again, have been used with some degree of success. And when all of those less invasive things are not helpful, then our hand surgeons can be very helpful in opening up the area so that the nodule doesn't get caught any further. Always a bit traumatic to be looking at that surgery, but it does have some very good results in many, many people. Now, if you look at this hand, so again, we're looking at a right hand, and I think if I look at the thumb and the index finger, they look pretty normal. The third finger is a little bit bent, and the fourth and fifth fingers are quite bent down. And when I look at this, as a rheumatologist, I would think, well, is this a joint issue or is something else going on? But if I look at this more dramatic picture, which again is looking at some changes, you can see that the tendon in this finger, this fourth finger in particular, looks really tight. Tethered would be the word. It's kind of puckered. It's made the whole hand kind of flex on its own. And this is what we call a Dupuytren's contracture. So Dupuytren's contracture is scarring of the tissue in the palm of the hand where the tendon becomes shorter and it gradually pulls one or more fingers towards the palm and also causes the palm to kind of bend on itself in the middle. It's most commonly to happen in the third and fourth fingers, although as you can see, the fifth finger can be involved. And it often will happen on both hands, although sometimes one hand more severely than the other. We don't know a lot about Dupuytren's contractures, although we do find that they are a little bit more common in people with diabetes. We know that overusing grip can sometimes aggravate things, and there has been some suggestion that tobacco and alcohol excess can be problematic. But on a more positive note, good blood sugar control can also be helpful in minimizing the risk or the sort of the aggravation of Dupuytren's contractures going forward. We manage these similarly to many of the other things we've talked about. So again, a very gentle therapeutic program of physiotherapy to work at some very gentle stretching. You don't want to further traumatize the tissue by overstretching it. Sometimes injections into the area have been used, and although cortisone isn't that helpful, it still gets used in some circumstances. But more recently, collagenase has been used by our plastic surgery colleagues, sometimes with very excellent effect. And then there are some surgical techniques that can be used to try to correct some of the changes that have occurred as a result of Dupuytren's formation. And then this is the last hand syndrome that I wanted to show you. So if you take your own hands and you put them together, you should be able to see that there's really no gap with the fingers and you can get the fingers totally straight, as compared to the picture where you can see there's a little bit of a gap. And so this is sometimes referred to as the positive prayer sign, but you can see this little area through here. And the reason for that, at least in the population of individuals with diabetes, is a situation called the diabetic stiff hand syndrome, limited joint mobility syndrome. Diabetic acropathy is another name for that. And it's where the skin and the tendons and ligaments in the hands tend to get thick and tightened. And with that, they lose range of movement, and the first range of movement that they tend to lose is the ability to fully extend or to get flat out. And so you get areas where the joint just can't fully extend, and we get the positive prayer sign. Gentle physiotherapy can sometimes be helpful. I often say to my patients, each morning fill the sink with some warm water and try to stretch your hands so that there's a little bit of a reverse curve in the hands to try to stretch what's happening on the palm side. And again, there is some suggestion that good control of blood sugar can help minimize the risk of diabetic stiff hand syndrome. So what I've tried to summarize is that we know that people with diabetes commonly have issues in the musculoskeletal system. It's important to be aware so that you can be proactive in terms of trying to prevent them, but you can also seek attention and to discuss those troubling symptoms with your healthcare provider, because although we don't have any cures for this, there are a number of ways that we can try to minimize the risk to the joints and maximize your ability to do what you need to do with your bones, your joints, and your tendons. I think on a very encouraging note, particularly for the group here, where everybody is so interested in doing the best for their diabetes, is there's good evidence to show that good blood sugar control is really helpful in trying to minimize some of these issues, and attention to exercise. And both of those are just so important for overall healthy life. So there are lots of different things. We've only touched on a few, but as you can see, important to keep in touch, important to chat with your healthcare providers and your team in particular, and to find strategies that are workable. And with that, I'd like to thank TCOYD for the chance of being invited into your living room today, and thank you for your attention. My best wishes for a successful rest of the conference.